So what's the life case? So we know. You don't know?
I don't know.
You don't know.
But actually in the program BTK.
Yep, it's BTK, so wonder if it's CTO or just a stenosis.
I guess it may be CTO in critical limb ischemia.
Yep, it's a good chance. Moderate.
Do we have a headphone? Do we know what's going on there?
He has it.
Yeah.
You know what's
Yeah,
happening?
yeah.
Are they ready?
Yeah, I'm ready.
Okay.
네. Yeah. So, can you start?
Yeah. Welcome, everybody. If we take our seats, we're just about ready to go live to Asan. I'd like to introduce my co-moderators, Dr. Choi and Dr. Burson, who are going to help us welcome in the live case. And I think Asan is ready.
Yeah.
So we can bring Asan live and start the live session. I'll ask the rest of the panelists to come up and join us. Thank you.
Hey guys.
Hey, how you doing, Mark? Can you hear us?
Hey, yeah, we can hear you fine. We are kind of in the middle of getting a sheath in here. Dr. Park is going to introduce our case here in just a minute.
Our case is a 67 years old woman. She was admitted for management of the left vein of the first leg for several months. Her ABI is right is 046 and left is 042. The low extremity CT angiogram showed the total occlusion at left SFA and the significant stenosis at right SFA. And also the severe stenosis was found at both common iliac artery and external iliac artery. On yesterday, she was underwent the balloon angioplasty and stent implantation at both iliac artery and left SFA.
So the stents were placed yesterday?
That's right.
So that's going to, so he's, obviously the operators here are going to be very careful. Freshly planted stents, one day is not enough time to let them really embed themselves, be covered over. And so have to be very careful not to displace those stents.
So she essentially, if you followed that, had pretty extensive reconstruction of both iliac systems yesterday, as well as the left SFA. And the goal today is to open up the right SFA. She has a pretty diseased, we can go ahead and pull. She has a pretty diseased common femoral on her left, which is where we got access. We started out with a micropuncture. Yep. We started out with a micropuncture kit. Maybe we could show a replay of that. Can we flush this, please?
So Bob, Mark, you're going to do the right leg?
That's correct. So we are
You flip-
accessing from the left through a common femoral artery that was just intervened upon yesterday with balloon angioplasty.
Is the patient prone?
The patient is we've flipped her on the table,
Okay.
but she is in supine position.
She's supine now. Because it looks like you're working on the left leg here. Is Is there
Yeah,
a-
they just haven't flipped the image.
is the image flipped on the
So it has been flipped up down, but
left, right?
this is it's a right leg that you're seeing displayed.
Right. It looks like the left leg here.
It feels like a left leg, but it's actually a right leg. So if we could go back to the preceding shot, I want to show you the left groin access. Can we do a replay on the previous shot, please?
플레이 전에.
And has she received heparin? So what you're looking at is a prosthetic hip on her left side, a micropuncture inner cannula only that we placed. And you can see she's got a high bifurcation, and this is a diseased common femoral. And as Dr. Park mentioned, everything that you're looking at has been intervened upon here, so we're in pretty raw territory.
Yeah,
and
I can appreciate that. And not to perseverate, you can just carry on as it is, but we're seeing the image inverted left-right.
Right. And I'm not sure if we can flip that
It's
in here
okay.
or not.
A vessel is a
I'm
vessel is a vessel.
I'm happy to have the feet at the bottom of the screen. So has she received heparin?
Yes.
Okay. So she's received heparin, and now if we could do a run through the last angiogram, the one that we just did on her right leg that looks like a left leg. Can we replay that image, please?
Left leg.
Can we replay the last run, please?
전에 거 말해봐 이거.
So your controller access means you're working across the table?
So we're standing on the side from which we are working. So we have access on her left, we are standing on her left, and
Okay.
we're working on her right.
Got it.
That way we don't have to put our hands in the field of radiation. Could I have a needle introducer, please?
Kind of my point, yeah. Perfect.
Now we can see the replay. So initially I thought there was going to be a total occlusion of the SFA proximally. You can see that there is a little channel in the proximal segment, and then there's that one little buckled area. It'll show up right there, where I can't quite tell whether that's an occlusion with like a collateral that's jumping it, but it's clearly occluded in the adductor canal. And then you can see that we do have some tibial runoff. So that's kind of where we are right now. Any comments about how to proceed?
From our panel, do we have any comments?
Well, this looks like a good one to try a wire-based approach initially. I would approach this with one or another medium to high gram strength guide wires. Take your pick, which one you're comfortable with.
014, 018, 035.
014 or 018.
Yeah, I think so too. I was just going to bring that up. I'm typically an 035 guy, but I like the idea of 014, 018 here because of the complexity of the lesion and your ability to pick through it. A little more control of the wire.
Yeah, so we have a CXI and a V18 control, and we kind of thought that same strategy. At least initially, we'd want to see if we can kind of pick our way down through there. And if can we get an image up on the screen now so we know how to drive through here?
And I know you said, Mark, that the adductor looks like it's occluded, but I can't be certain there might not be a small microchannel there you could slip a jacketed wire through.
That would be ideal. Yeah, I agree.
아까 이미지.
So while he's working there, we didn't really see the tibial runoff that well, but you know, we saw the proximal vessels. Are they pretty well intact on the CT angiogram, or did you do other imaging of the distal tibials?
So we have a CT. That's the good news. Bad news is it's a year old, but it did show patent tibial vessels a year ago.
No, that's good.
And let's pull up the image here again of our second run.
I don't know how it is for you. When I see them ghosting
freeze it.
following a long total occlusion, a long area, very heavily diseased, and no, I'm never going to have enough flow to really image them well. I usually take it on faith that there's something there and fix the proximal stuff and come back to whatever the job may be.
And then take a good image after.
Yeah, exactly. Making
Yeah, we're doing a lot on faith here. Let's just do a little, actually, can we try road mapping? That's good.
로드맵 어떻게 하지? 로드맵. 로드맵.
In the United States, and after the decolonization of wire and the use and the developing device, such as diamond or something in this region.
Sorry.
In this developing device and such
Yeah, I mean,
as
if you could,
diamond.
this would be a great case for a jet stream if you could get through it
Jet stream is
and place a distal filter. This is an awesome case for that because long diffuse disease, heavily calcified throughout.
Are you ready?
This is the prototype for a jet stream case. The key is whether they can make an intraluminal passage.
So let's get that image up. I'm not sure we're going to be able to road map here, but if we can store an image, that would certainly help.
Dr. Bucket, good to see you. I'm Dr. Ra from Korea University.
진석이 좀 불러.
Oh, hi.
Uh,
Good to hear your voice.
yeah, the V18 is your primary choice in usual CTO intervention in SFA? V18. And take
So
rate.
if it depends on the
V18.
CTO.
Okay.
It depends on the CTO. If I think there is a long, heavily calcified total occlusion, then I would typically not use a V18. I'd probably go to an 035 angled glide stiff.
Yeah, but this is a short segment CTO V18. I also frequently use the 18
좀 불러봐라.
connect to flex wired for this kind of. The main issue is that this looks very dirty, calcified, and very heavy plaque burden with calcification. So in Korea, if I do this case, I would prefer to do the jet stream for the debunking,
할줄 모르잖아.
or we can do the scoring balloon together, and then considering the non-composite balloon, and depends on the balloon response, maybe we may consider. If the balloon response is very favorable, we can finish with the DCB. What is your primary strategy today?
That is a great question. We so far have only discussed getting across this thing, and we have yet to discuss
뭐 어떻게
our
하면 돼?
end game. I thought we were going to be dealing with a long segment total occlusion. Yes.
얘는 뭐면 어떻게 하면 돼? 지금 하면 돼? 하면 돼 이제? 쏘면 돼?
Mark, it looked like when on your last splash of contrast that origin of the SFA probably kicked off to the left of this screen. I don't know what that is for you.
쏘면 돼?
Here.
됐어.
Yes.
Yeah.
Yeah, medially.
Right. Medially. Well, no, that's all. That is occluded now. See the SFA here?
Yeah, so you can see the calcium outline. What I'm trying to do is advance the CXI with my left hand while I get just hold the wire there. I want a little bit more support. Things are not exactly moving as, there we go. So there's the CXI.
Yeah, it looks like it may have just shut itself down while you're working there. Do you have the
Yeah.
patient anticoagulated yet or not?
So I'm told that they're fully heparinized.
Yeah.
So, Mark, just to make sure you understand what our plans are here, we'll watch you for a little bit longer here. They're almost ready with the BTK case. So we will probably cut from you in about 3 to 5 minutes.
Okay.
So you have about that much time to finish the case.
Okay. Yeah, we should be done by then, I think.
So
Hopefully
we
we'll
have
be
one
done
vote for
getting into
debulking this. It's heavy calcium dialysis patient. Jet stream has been mentioned. Other approaches, I mean, you could debulk just the proximal disease and the short segment occlusion with a TurboHawk too. That would be something you could do. You would need an embolic protection filter for sure. But I think everyone feels here that the calcium content's heavy, and you're dealing with at least 4 or 6 centimeter CTO, in addition to heavily calcified high-grade stenoses above that.
Yeah, I think the other thing is that the jet stream is front cutting, the TurboHawk or the Hawk 1 is side cutting. And if there's really a total occlusion which is heavily compacted by calcium, I think it's sometimes
We do
tough
a
to
little
get that
puff
nose
of
cone
dye
in
there,
there.
please.
Yeah, you probably have to pre-dilate.
Yeah, and
Jet
then
stream,
you
I
kind
think,
of-
would be a good choice.
Then you kind of
Some
defeat some of the
dye,
purposes.
please. Thank you. So yeah, it looks like the SFA has shut down
Yeah,
while
it
we
does,
were
doesn't it?
in the midst
Yeah.
of this. So let's angle out a little bit steeper, and we'll do a good shot and see if we can figure out why that would be.
You must
And
have,
again,
just try the road, just try to follow the calcium on that steep LEO.
Let's go out a little bit more on LAO, please. And we may need a little bulkier wire, we'll see. This
Yeah, you can see
wire, we're really losing torque as we go around. You can kind of see the wire snapping there. So I don't know whether simply bringing that sheath in may have pushed some debris down that interfered with flow. The initial shot was done just with a JR4 diagnostic catheter.
So Mark, I think your sheath may be a little close to the origin of the SFA. That may be the issue. And that you may not be filling it. If you just pull back a little bit on your sheath.
Let me back it up. I
Just an
thought
inch.
that might be
There you
the
go.
case. and,
Because
let's-
in a
let's take
steep
a pulse there
LAO,
and see.
you're going to have that
Go ahead and
appearance.
puff there again. I hope you're right.
Yeah, there it is.
Yep, very good. Thanks. Yeah, I brought it back a little bit, but I didn't bring it back far enough, so that's very helpful.
This is a great lesson for everybody in the audience. When you go to that LAO or RAO oblique to make your bifurcation more apparent, you artificially raise what looks, it makes it look like the bifurcation becomes even higher, when in point of fact it's just related to the LAO or RAO angulation. So we got fooled, all of us, by the fact, we thought the SFA was occluded, when in point of fact it was just beyond the tip of his catheter was beyond the tip of the origin.
You know, you have enough flex on the wire now where you may want to reshape it. It's almost like it's
I prefer the GL diagnostic catheter for this region.
Yeah.
Yeah, so I brought we're just using a straight catheter. This might be a great time to have a curved catheter, and as you can see, every time I flip the wire, it
Yeah.
flips away from the SFA.
So Mark,
just gonna-
this may be good news or bad news for you, but we're going to go to the other case and let you
Okay.
get into the SFA off camera.
All right, sounds
All right.
fine.
All right, we'll
Let's
see you in a
try
little bit.
Let's try to pull this, and
Okay.
we'll try a little different shape here.
아니 쉐입을 바꾼대.
Okay, we're going to go to Son case number 5, Dr. Lee and Dr. Cho.
Yeah, I'm Dr. Lee. Could you hear me?
Yes, we hear you fine.
Yeah, thank you for coming our meeting. Really appreciate it because of the some tension between North and South Korea.
We hadn't
Sorry.
heard that. What's the problem?
No problem. Okay, I introduce my team. Is left side is another hospital, veteran hospital, Dr. Lee, and another right side is Dr. Lee from the Donghua University Hospital. So today's case is we introduce our case. Dr. Joe.
I would like to present this case. The patient is 66 years old man, and his presentation is right pivot wound. The CT angiography showed total occlusion of right posterior tibial artery. He has long-standing history of hypertension and diabetes, and he is a smoker. So we treat to left posterior tibial artery.
Now we check the baseline angiography. Baseline. Okay. CT angiography 볼 수 있나?
Yeah.
Okay, you can see the heavily calcified, the routinely encountered the routine practice, long-standing diabetes. This patient is not end-stage renal failure patient.
We're having trouble hearing you from your microphone. It's a lot of static.
자, 안 들리나는데?
And the image that we have is upside down. Is that the way you see it also?
Yeah, this is my practice.
Okay.
So you can see the heavily calcified region usually need the strong backup support. So I enjoy usually the ipsilateral puncture and initially angiographic check. Heavily calcified in the SFA and some region in the distal SFA. And the cine angiography showed BTK region to see exactly the region status. Distal SFA is some narrowing. And this is the BTK, cine angiography. The a little bit flow in the ATA.
Yeah.
So ATA flow is the black, the distal dorsal pedis artery, and the posterior tibial artery is occluded in proximal to mid portion, and there is no distal target region of the PTA. The patient history is recurrent of the wound in the fifth toe. So the patient eagerly wanted to reach the vessel and he wanted to improve the wound healing. So this is the dorsal pedis artery angiography. Some collateral and flow is reached the fifth toe. However, I think not enough to improve the wound healing. So heavily calcified region and recurrent wound is commonly encountered in real practice. So could you give me some comment?
You're a brave man to take this case live. Very difficult case.
Yeah. I think maybe success is not so high, around the 50%. Very difficult case.
So you have antegrade access?
Yeah.
That's helpful, right? So what is going to be your equipment choice, and what's going to be your target? What vessel you're going to target, and how are you going to approach this case?
Based on the angiogram-based approach, maybe ATA. If we open the ATA, maybe improve the patient wound. However, we already tried the ATA with the command Y and the backup support with the balloon, small balloon. However, the Y is not easy because the heavily calcified region.
I think they're going to need to switch out your microphone. The sound here is very bad. I know they just tried to fix you, but it's not working. We got a lot of static. Very difficult to understand your voice.
Just a moment.
So you tried to fix the anterior tibial?
Yeah.
What?
The proximal portion of ATA looks good. However, distal, you can see the distal dorsal pedis artery is occluded. So
It's always difficult to fix any artery that doesn't have an identified outflow vessel target. It's very difficult.
Because of the calcification, always problem and challenging. So we already tried the ATA, however we failed the wiring, and now we moved to the posterior tibial artery. And insert 1.5. And we moved to the posterior tibial artery. However, as you know, see there is no distal target. So this is a very difficult situation. In this kind of situation, usually we don't try. However, the patient eagerly wanted to wound healing, so we try to just blind wiring, and if needed, the subintimal angioplasty we can do.
Which wire do you have there in the posterior tibial?
My workhorse is usually the command wire.
Okay.
So now we advance the wire like this subintimal portion. Advance slowly. However, I think the wire is located in subintimal space, not inside of the calcium. There is some worry. And now reach the balloon is in the distal part of the PTA. There's no option, just pushing. Could you give me some comment?
So this kind of very heavily long calcification doctrine, and using the command, I think the lower tibial and the below ankle, the usual our subintimal 14 wire subintimal tracking is done more subtile wire like Regalia 1.0 or the Hydro ST or Journey. However, due to the friction coming from this dense longitudinal calcification, 2.8 gram command, like your choice, or the command ES will be a better option to push away the calcium. However, still less, it's weaker than the 3.5 system. So until the ankle level, I prefer to do the 3.5, 1.5J preformed Terumo wire under the angiocalcific support. Then we can switch it to 14 wire system to the below ankle. Otherwise, it's very difficult. Even after the wire passage, further balloon passage will be difficult with the narrow
Why
space.
stop here? Why stop?
So it seems to me, looking at this, that this PT occlusion is more chronic, and I wonder if the acute event was the anterior tibial or the dorsalis going down acutely. So I would almost, persist on the dorsalis first to see if I could restore flow to the arch, then try to open this calcified, what appears to be very chronic occlusion of the PT.
Yeah, I think that is not possible to pushing the wire.
But right now you are using the small balloon supporting wiring.
Yeah.
Oh, how about change the guiding support catheter? Well,
Which line? Which section?
Yeah.
So wire and balloon is stuck. The major wire damaged, and then they did not separate from the balloon. We moved to the old system.
So I think one of the challenges of subintimal angioplasty, while there might be some advantages, you really need to re-enter the vessel at or around the ankle. And that's not always in our control. As you can see here, it's very difficult to do. And so I try to avoid subintimal angioplasty whenever possible, only because especially when I know that the re-entry is going to be at or below the ankle, and that's going to be a problem for me. So I don't know, Bob, what's your style?
Well, yeah, especially it's better. I think I'm more comfortable doing it bottom up than top down.
Right, absolutely. Because you can re-enter a larger vessel. There's no real end point there. There's not a hard out.
Yeah, here you have no target.
Right.
I know this situation is a very embarrassing situation. So now we're checking the again. USA. Much improved. So, checking the distal portion. Okay. Oh, there's some flow. I don't believe it. 예, 아프시죠? The patient complained of some leg pain. 약 들어가서 그래요.
중해요? 아, 저기.
Some interval. We massage the low leg, make the continuous return. 아프시죠? 예, 병원에. 네, 힘좀 빼세요. more and more. 오케이. balloon. 다시 주세요. Comment please. So I tried again in the
new one.
distal part of the
예.
TTA. I think maybe success rate is not so high.
balloon.
Recommended.
하고
So I think what we'll do, if it's okay with you, we're going to flip back to the other case,
XT.
and we'll come back to you in about 5 or 10 minutes, and we look forward to your success.
Okay, thank you.
Okay, good.
발론 뭐 드릴까요? XT?
Mark, you're back with us.
Okay, sounds like we got the easy case here.
I'm not sure. It's a coin toss at this point.
Okay, so what we did is we took the V18 control wire, and with your suggestion, with the sheath back, we were able to reshape it and then get into the SFA.
Great.
And kind of advance the CXI and the V18 control together, and we were able to get through that occluded segment in the adductor canal, passed on distally where we confirmed we were in true lumen, and then can we show a replay? Took a shot through the CXI in the popliteal. It was that one that right here. And then we saw that we have something else in the popliteal. And so we reintroduced the V18 control, advanced it again, took another shot, which you'll see here. And so this again is through the CXI, so pretty poor visualization, but you can see that we do have some tibial runoff. The patient was fully heparinized, and so well actually I'd like to reopen the issue of the pathway, keeping in mind that we now have a 6 sheath in. with a very diseased left common femoral, fresh stents in both iliac arteries, and it was somewhat difficult to introduce a 6 French sheath into both sides. Both the right and the left were hard. Does that give anybody pause about putting in a larger sheath and a pathway?
Yes.
Yes.
Okay.
So one of the options you could do, which I've never done before, but if you had to stick with the 6 sheath and still wanted to debulk, you could use one of the smaller pathway devices or the CSI. I think it's too long for CSI. I don't like CSI for this. There's a lot of disease coming down there.
Well, you can do it. You just have to have a filter, and it
Yeah.
will fill up. You
Yeah.
know, and your runoff is limited.
Yeah, it's a very limited runoff. That's the one thing working
And
against
you'd
you.
probably have to leave the filter above the popliteal lesion. So, maybe
So-
not. No, it looks like maybe you could put it below.
So
Might have
what
enough
we
room.
have, we kind of discussed the whole issue of embolic protection, larger sheath, pathway, et cetera, et cetera. I don't know if you can tell, she's getting a little rambunctious on us right now. But we're going to wimp out and see if we can get a small wire through and then a low-profile balloon and do an initial balloon inflation and kind of see what we get. And I realize that everybody, including me, would much rather, we're going to have to get her leg on the field of view here. Including me would much rather do atherectomy here, but I'm kind of concerned about increasing this procedure in order of magnitude and complexity.
Yeah, it comes from years of experience.
Yep. So that being
I-
said, are you thinking a stent solution here with all the heavy calcium and the complex disease?
I'm thinking that we would be lucky if we got out without a stent.
Yeah, I think you're going to
So-
need a stent, yeah.
So I think we're going to start out with a 14 wire. It was actually difficult to push the CXI through the occlusion. You can kind of see from the fluoro image one reason why I'm not interested in making this more complex than I have to. At any rate, we're going to try to keep it simple. I hope that simple really stays simple. Sometimes you try to do something simple, and that is why the procedure gets very complicated.
Are you through that most distal popliteal lesion? It looks like you are.
Yeah, so the CXI is through, and you can see at the 14 wire, let's stay ahead of the wire,
That's
please.
great.
So what do you want to do with the popliteal lesion? I think it's right in the bend segment, isn't it?
Yeah, so we're just going to start out with a 3 millimeter, 10 centimeter length balloon, and kind of see what we get after that. So let's have you do the exchange. I'll hold the sheath.
Are there
let's
Superas
just
in Korea? Do we know?
Wire down.
Do you have Supera stent?
Yeah, of course.
Good.
Yeah, the other option here, but I doubt they have it, is the Hawk 1 6 French, which also has an extra long, that would be for the popliteal lesion, I'm thinking.
Right, but you'd have to get it there, so you have to do a little predilation ahead of it.
Right.
Yeah.
Let's go ahead and put the balloon on.
I mean, one way of approaching this would be to do maximum balloon dilation, maybe a specialty balloon, maybe not, and then DCB, and then Supera,
That's right.
which is kind of the way I usually handle this, if I can't atherectomize.
So we're going to put
like there was
we have a 3 millimeter by 10
Segment
centimeter
between
balloon,
the
correct?
popliteal lesion and the occlusion.
There is.
120, oh, that's even better, yeah.
In case of short popliteal lesion with a heavy calcification, in the case I prefer to use the jet stream rather than the other atherectomy device or balloon. Yeah.
Minimize your stent implantation, yeah. The problem is getting a 7 French sheath in here, and it's not going to be good.
Yeah, I really have some reservations about crossing even with a 6 French sheath around that bifurcation. Okay, so I'll have you keep the wire right there, and we'll advance this balloon in. So right now we're advancing a 3 millimeter by 120 millimeter balloon, and I think we'll just, if it passes as far as that distal lesion in the popliteal, we'll just dilate there just to kind of get a channel.
There it is. There it comes.
So as I mentioned, it was tough just to get the CXI through there, so I'm glad that the balloon track.
Yeah,
Could
that
we
went pretty
go
well.
to the could we go to the stored image that shows us where that popliteal lesion is then?
아까 퍼프트를 한번 볼까?
That's that one right there. When you see the lesion, just store it so it's right about the
mid-patella.
level of the mid patella, right? So I think we're good right there. So
Yeah,
let's center the balloon up. And we'll go ahead and inflate. And I think what kind of pressure this takes is going to tell us part of the story about how this lesion's going to respond to balloon only.
6.
So it's kind of hanging on in the adductor canal, but all in all, that's not too bad. We're at 11 atmospheres right now. I think we need to go up higher to get that adductor canal region. And what's the rated burst on this balloon? We want to make sure we get our money's worth out of it.
퍼스트가 얼마죠?
14? Let's go up to about 16.
16.
Yeah, I agree, that's encouraging.
Yeah, I still am a little concerned about that area right where the femoral artery, or where the popliteal artery crosses the femur. I think we're going to end up with some waste there. I think what we'll do is we will deflate the balloon and then we'll just do an overlapping inflation and try to hit that again right in that region.
앉아 좀 봐주세요. 앉아 좀. 깜빡스 봐봐.
So this is only a 3 millimeter balloon. It's a pretty small artery. It's not that big. I mean,
Yeah,
if you look at the
the,
relative size of the balloon versus the artery.
Yeah, the result on the contralateral, let's go up again. The result on the contralateral femoral artery was kind of rough. I mean, it was she's really got extensive disease, and
Yeah, it's still there.
so she really had good flow on the left leg at the end of the procedure, but it was certainly not a beautiful, wide open lumen. I think it's really diffuse disease that we're starting out with.
What is the current balloon name and size, length?
So this is a 3 by 120.
이름 뭐지? 이름. 나노크로스.
And let's go.
Electronic
I think we can come down.
Nanocross.
You're up at high pressure.
So are you
메토닉.
That's 15
considering
atmospheres.
are you
Yeah.
considering a non-compliant balloon after this?
I think what I want to do is see the vessel and then decide about a larger balloon, but I think a non-compliant is a really good point. Okay, so our distal marker is down there around 39. We'll just we'll keep the table right here as we bring this up. And let's go up there to 15. I think now that we have a channel, at least, we have the option of using a variety of different balloons. I was concerned just about crossing with the balloon initially, but I don't think that's going to be a problem now.
So will you swap this wire out for a 35 wire to do the rest of your work, given what you anticipate you might have to deliver here?
I think that's a great idea. So we can put an 035 balloon over this, and then we can swap out wires. Okay, I'll hold the sheath if you want to bring that balloon back. Hold the wire and bring the balloon back. I'll hold the sheath.
So when they asked Michelangelo to carve the David, they gave him the best piece of marble in all of Italy. You do not have the best piece of marble in all of Korea here, so we don't expect a David.
I'll be happy to get inline flow to the foot, I think. Inflate. So I'm pretty pleased with the way the balloon's inflating. Frankly, I was anticipating that we were going to have more trouble inflating, but this is responding pretty well. So we'll just leave it up for about 30 seconds or so, and then we'll come down, do an angio, and then kind of come up with our next strategy.
Right, I would agree. I want to see how it's looking before I decide anything else.
We'll look at that angio, discuss your strategy with you, and then maybe we can go back to the other room. Okay? We'll check on their readiness. They have a tough case, as do you.
Okay, let's come down. And then I think no matter what, we won't be using this balloon for the next inflation, so let's...
So that was 4 inflations. It's about a 40 centimeter. So
it's
a
120...
task D. Calcified task D.
It's all of that.
I was going to make it a task E.
Yeah, right.
Let's go ahead and
Task K.
So we know the results of POBA doing that.
Right.
Right.
Palliative at best.
Right.
And then if we could have a 20 ml syringe, I think we'll get a better angiogram here. And that balloon is out. Do we have a 20 ml syringe? I think a 10 is probably not going to fill this.
That's true. You know, for most lower extremities, I mean, we use a 20 cc control syringe. You just really need it.
Yeah.
To visualize.
And usually what we'll do is we'll use a 20 and then dilute it 50-50, and so you get great opacification, but you don't use a ton of contrast.
So I don't use syringes anymore. Everything's power injected, half strength.
We use power.
Yeah.
I still use my hands.
That's why I don't know what to do with the manifold anymore. This morning's case, I was looking at the manifold like it was from Mars.
Okay, I think we're set. We'll go ahead and inject now and take a runoff shot. Here we go.
It's more better.
Well, it's open.
It's definitely better.
And we got at least one vessel.
I think it's fair to say an angioplasty result is not likely. So even if the bigger balloon, you can see.
What do you guys think about now going with a scoring balloon? Would you go with the scoring, larger compliant, larger non-compliant? What do you think?
Yeah, there's nothing wrong with scoring. I like that. You can take that usually up to 16 without getting in trouble.
I mean, you'd like to avoid a complete stent column here, right? So I like trying something else to see if you can optimize things and then just spot stent where you have to.
In Korea, you can use the vascular scoring balloon,
Yeah.
or non-compliant
Like a
balloon.
5 millimeter Vascutrac, or do you have a Vascutrac, 5 millimeter?
If they don't have, maybe recently launched it. So if they don't have, you can directly do the NC balloon, non-compliant.
So if we have a plan to use suprastent in calcified region, so we have to dilate, fully dilate. So in the case, we have to use the non-compliant bigger balloon.
I think so too.
Yep.
The Vascutrac, in my experience, when you take it to high pressures and calcified lesions like this, I've actually had it stick and not deflate. Have you had that happen?
I've had that happen, yes.
And I've actually had to poke the patient's leg to deflate the balloon, to puncture the balloon.
That sounds exciting.
Yeah, I don't like Vascutrac and calcified lesions because I like to take my balloons up high. So I don't recommend that. But
아니면 아티반이나 있나?
So I don't know if you can gather the...
angioskull's fine. Yeah.
Do we have an angioskull? Let's see, we have a
Okay.
5 by 2 centimeter cutting balloon. We'd be here all day using that. No angiosculpt balloons, is that correct? Okay. Why don't we use a 5 millimeter non-compliant balloon? What do you have in a 5 millimeter non-compliant? Yeah.
그 나노 크로스 같은
The
거
longer the
하고
better.
So Mark, we're going to cut to the other room, and
Okay.
we'll come back and see the results of your predilation.
All right.
Thanks.
그러니까 이빨 들고 와.
Okay.
Okay, we're back.
Okay, welcome. We discussed another strategy. You can see we tried to ATA again with the subintimal angioplasty. However, the wire does not work. And then we changed the hard wire, the Astato 20 gram. The wire is will reach the perforating artery around the, however, balloon does not advance.
This is the Astato, you said?
Yeah. So we checked again, the angiography, much improved. Before the intervention, there is some scanty of the blood vessel. However, after subintimal wiring and PTA, I don't understand.
I don't understand either.
Vasodilators?
Do you prescribe vasodilator something? Nitrate something?
Yeah, nitrate is.
Did you take the initial angiogram with an antegrade catheter also?
Yeah,
Yeah? Okay.
just normal.
I agree it's better.
Yeah. So we rechecked from the 80 portion. Okay, here. 이거죠? 야, 빼고. Now we changed the sheath, the answer 5 French sheath to the 7 French to make sure the proximal SFL region treatment. Okay, 앉아. PTA proof.
Maybe that's why you have
Really
better pictures. You have a bigger French size sheath,
Yeah.
more flow. But in any event, it looks better.
So, 자. PTA is flow is improved. Maybe just the wiring is the subintimal space, some space and the contrast is going down. However, the ankle portion is we did not advance anymore.
Didn't quite follow. He said the wire went down to the blue one.
Always this kind of the poor distal target and heavily calcified region is still problem. Could you give me some advice?
Actually, this patient wounded area, in considering angioson concept, ATA must be target, right? So, ATA, the no distal stump, I used to do the subintimal wiring, empirical wiring first with the command ES, but you tried before, failed. The Astato intraluminal CT attempt is dangerous. You can make just easy perforation. So command ES will be the maximum test. And the second one is the subintimal, the microcatheter support, the subintimal below ankle angioplasty. They can be feasible with Regalia 1.0 or the more soft wire like Joni or the Hydro ST. You did not try that. That is the very, very safe way. The below ankle subintimal wiring under the angiocatheter, the microcatheter support. Third one will be the flushing technique. You can place the angiocatheter near the ankle area and the nitrosaline convert, and suddenly you can make hydrostatic pressure-induced re-entry to the invisible distal channel. That is worth it to try. So that will be the last option for this patient. Because you cannot do transcollateral and retroited by the adjacent peroneal or the PTA. So this situation, if we want to maximally open the ATA territory, and these three recommendations will be the last choice. Or just to leave it with Baker therapy and foot care.
Yeah. I think you can see the abundant collateral from the proximal dorsalis pedis artery, and because of poor distal target is always a problem to make success.
Yeah, I think most all of the digital arteries are chronically occluded. You have a huge plexus of collaterals right at the arch, but there's a void of any filling down at the digital spaces. So I think your arch is all obliterated and your digital vessels are occluded. So I'm not surprised the Estado didn't go, or if it went, it probably went outside the vessel and the balloon would not follow because it exited the vessel. But it's probably all chronically occluded. I don't see any good distal target.
Personally, I would take this as a success, and I would see how the patient did with wound care.
Yep.
Yeah.
And you can always come back. Many times these vessels will open up even more with time.
In my case, I'm always trying wounded patients with
Yeah.
below ankle subintima. However, now the first circulation looks okay.
looks
I
a
don't
little
know
better.
the initial the baseline angiography. He did not give forceful injection.
Right. Who knows?
However, after the PTA, the wiring and something make a space in the
The
PTA.
PT definitely has some flow. The AT has a better flow into the pedal loop. I'm not sure why that happened, maybe just manipulation. But there's no question there's more contribution to the foot from both vessels. I probably would stop here, especially since there's no distal targets.
There's a
No
message.
distal target. You can
message
make it worse.
Yeah, I don't want to touch and I don't want to damage to the collateral because of the collateral is relatively abundant. So I think the limb viability is no problem. The wound healing a little bit delayed or whatever. However, I hope the wound will resolve sooner or later.
I think we've all had the experience where we do a little bit more, we pull up a balloon, and then the flow shuts down, you know?
Yeah,
And
yeah,
so
yeah, you
I
don't
would,
wanna go there.
I like this result for now. I like the idea of the wound care.
Yeah.
And,
Hyperbaric oxygenation and the medical therapy is the
Take your
the
winnings.
best option. Yeah.
Very good.
Did you perform
Thank you.
balloon angioplasty for the PTA? Did
No,
you perform
just the
just
wire
wiring?
pushing.
Push with the
Wire,
balloon.
pushing the wire and pushing the balloon make some space. Maybe the contrast going down. So I wanted to stop our procedure because of I don't want to damage more. Any question? Any other comment?
Thank you, Dr. Lee.
Okay. Thank you.
One thing you could do if you wanted to get, if you want to really optimize everything is do that anterior tibial distally had a little stenosis in it. You could touch that up, increase flow distally. Mark,
So
you're going
sounds
to take us home here in the next 7 minutes.
So I think we're well on the way to home, actually. We put in a 5 millimeter balloon. We have a 5 by 80 in. And what I'd like you to see is we filmed the balloon inflated at 8 atmospheres. Let's start with the most distal inflation. Let's do a replay of that. If we could go all the way down to the popliteal, right where it was in line with the patella. So down here was the distal lesion, and everything yielded. That view right there. Do you see the balloon in the popliteal artery?
Yep.
Okay. And then we moved it up to the adductor canal region. Everything popped open at about 8 atmospheres, which kind of surprised me. So I don't know what we're going to get after we do these inflations. Let's come down here. But we've been doing a series of inflations with a 5 millimeter balloon. Again, our first balloon was 3 millimeters. And I'm halfway thinking that we may have a somewhat decent result at the end of this.
Is this
Maybe
Mustang
over-
or the Conquest?
This is actually another of the, I'm blanking on the name. This is what balloon? Go ahead, go up. It is not a non-compliant balloon. And I'd take it up to the same pressure. Yeah, all that stuff is yielding at lower pressures than I would have thought. I think if we get a halfway decent result here, I would be inclined to just do DEB. Now, if we don't get a decent result, then it becomes more difficult to decide what to do. As you've said, leaving a whole column of stents in this vessel is not a great prognosis for the future. Any thoughts? If you guys saw a good result after this 5 millimeter balloon, would you be happy with a 5 millimeter DEB?
Yeah.
I suppose, although the degree of calcification is heavy, and we know the effectiveness is less. But anyway, let's see how it looks.
But at least if it fails, it's not full of stent.
True.
You
Right.
come back and sort it out, right?
I think you want to avoid,
You could atherectomize,
column.
you could atherectomize then
yes.
with a less freshly implanted series of iliac stents.
So we'll go up to the inflow here, right about there. Let's go up there. Okay, we'll leave that just for a little bit. Then we'll get this balloon out, we'll take a picture, and see if we can declare a Vietnam here, declaring victory and getting out. Let's come on down.
So we have 5 minutes, Mark.
Okay, let's go ahead and do the exchange out. Now I'll hold the sheath if you want to do the exchange out. Leave
And
the
you still have
wire
a
in.
14 wire in there, obviously, until you make your final
That's right.
decisions. Yeah.
Yeah. So it'll take a while to deflate. So kind of taking a minimalistic approach on this, given what she's been through, and I wish you could be here to get the full effect. This kind of reminds me of landing. I've never landed a airplane on an aircraft carrier, but I imagine that this is what it's like. Okay, let's do another injection down through there with that 20 ml syringe.
Probably not as many people watching.
Okay, and let's move just a little faster this time because I think the die is going to be moving a little faster. Ready to go? Okay. Got a big tear up proximal, tear there.
Well, a lot of it looks
That's
good.
pretty
You just
good.
have a big tear up top, maybe just spot stent.
Pretty
that.
good.
Yeah. Got good flow down to the foot. A little bit of waste there. Could we kind of walk through that a little bit slower, please? Can we just do a replay, but do it a little bit slower so we can see what we need to touch up?
Flow is really good, even with the tears.
So I think that proximal area we could hit again. The flow right there at 40 is good with the tear. I'd be okay with a long DEB inflation there. All the distal stuff, I'd be happy with the DEB. Can we kind of march it back up now?
You know,
Are
all
you
the-
guys okay?
Yeah, all the DCB is
40
going to be
down.
3 minutes anyway, so
Right,
you don't know what you're going to get after that. It might be pretty good.
that's right. So let's look at that proximal stuff again.
The proximal looks pretty nasty.
So there's that
Yeah, but
waist.
I agree, but watch how quickly the flow is. I mean, it pops right through there.
So right at the origin, there's a waist, and then at 20,
That's,
about
yeah.
27, there's that big linear tear. I think a stent at that
I would
20
favor
something
DCB the lower and put a DS at the top. I mean, it's going to need it at the top.
Yeah,
Oh, the other thing you could do is just DCB the whole thing and provisionally stent whatever you have to with bare metal at the top.
yeah. So why don't we get a 5, we're going to get a 5 by whatever the
What's your
longest
preferred?
intake
Do you
is.
like to go ahead and
그 5에 150
DCB or DES?
Well, I mean, that's the provisional strategy, but I see this as it's already disrupted to the extent where it's no longer provisional. That's why I would just go to a DES at the top.
See, sometimes even up to the DES, I mean, I don't know. I guess it's a 10, 20% chance that might have
Wire has to go farther.
avoided all
Yeah.
metal.
Doesn't look likely, but
Yeah.
Yeah, I think,
I agree, it's
we might
unlikely.
get a great looking result after a 3-minute inflation. We were kind of rushing the inflations. I think if we got a great looking result after a 3-minute inflation, I'd be okay walking away even from that tear.
I think,
Okay,
you know,
go
it's
ahead and
unlikely,
try.
but still possible and worth a shot. Yeah.
can try it.
Okay.
And I agree with you guys that if she comes back, you can always do atherectomy then. I'd be more comfortable putting a bigger sheath in after those stents have endothelialized.
So, Mark, first of all, terrific case, and well done. We're going to have to break here. We're right at 3 o'clock. But congratulations to everybody there, and good luck finishing it up. We look forward to getting a full report when you're back.
Well, thank you, and thanks for your comments from the panel, very helpful.
Okay, take care.
Good job.
Thanks. I'd like to thank our panelists, Dr. Choi and Dr. Burson. And we'll break to the next session.